This conference will now be recorded.
So good evening everybody, this is Dr. Aman and I'll be taking your video lectures on oral pathology. Very interesting topic, I would say. It is an interesting topic definitely, but I know when we read this subject in our third years, it wasn't that much interesting because the interest wasn't created, I would say, or we didn't take that much effort that we could create interest out of it. But frankly, if we know the things, it will be very interesting for all of you. Please do cooperate, please do keep your focus. What I try to say, we'll try to learn things and remember things and understand. We'll try not just to cram. Okay, so we'll start with the first topic, that is developmental disturbances, and that is very important topic. See, it is not just a coincidence that first chapter in oral histology was development of tooth, and first chapter in oral pathology is developmental disturbances of the face and the teeth. Right, so it is not just a coincidence. It is, see, whatever we read in first and second year will help in our third year and final year subjects. Right, so if we are aware of oral histology things, the oral pathology will become little easy for you to understand. Okay, so moving forward to the chapter, the first chapter is developmental disturbances, and for that I'll take you through certain basic terminologies which you need to understand in the development of things, right? One is physiological development and other is the development which with abnormalities, right? So basically developmental disturbances are the disturbances which occur during the embryogenesis of various structures of the head and neck or the face or the teeth or the jaws, right? So during their embryogenesis, the disturbances which occur. Okay, so I'll take you through certain terms. The first one out of it is congenital defects or anomalies. So one is congenital, second is hereditary. So two terms which are used very commonly and but not with much clarity. Okay, so congenital defects are basically the defects which are given to the child, in fact, just before birth, during birth, or immediately after birth, right? Means it is not, I'll just go through this thing. It is not necessarily inherited or transmitted by genes. It does not runs in families, right? It will be, if it is present in a child, it will remain to the child. It will not move to the next generation of that child, or it wasn't present in the parental generation of that child. It was first time seen in that child, that is congenital, right, during the birth of the child. And the most common example of it is congenital syphilis. Means you can say the things which are transferred in the form of infections have higher chances to be congenital, right? So this is, I think, is easy to understand. Second term is hereditary defects or anomalies. Hereditary defects are basically which actually runs in families. It is a genetic defect which is transmitted by genes from one generation to the next generation to the next generation, right? It runs in families. That is hereditary defect. So I think this is clear with both the terms. Congenital and hereditary both are different etiologies. Hereditary is in families, congenital is limited to that generation only, right? So moving forward to next important points, one is autosomal dominant and second is autosomal recessive. I'm sure in subconscious mind we are aware of it, but when question comes, why I have put these images here, because I'm not audible, guys. Okay, I have put these images because this image was asked in AIMS exam. I'm sure you all know that AIMS is an online exam now and it has 200 questions, and AIMS has maximum number of image based questions among all three exams, PGI, AIMS and NEET. AIMS has maximum image based questions in its examination, and one of those questions was this, right? This image was present there. What they did was they gave this image in the question, they gave this pedigree, and the options were autosomal dominant, autosomal recessive, X-linked dominant, X-linked recessive. These were the four options, and you had to identify. They are talking, this picture is representing which type of inheritance, right? So that is why you need to be aware of these images. So first is autosomal dominant. I'm sure you all know what is it. As name indicates, it is autosomal and dominant. Autosomal, by autosomal means there are 23 pairs of chromosomes in human body, out of which 22 are autosomal, somatic, and one pair of chromosome is sex-linked, right? That determines the sex of the individual. So autosomal dominant, autosomal chromosomes are 22, and 2 are sex-linked chromosomes. Right, so autosomal dominant, this type of inheritance will be seen through autosomal dominant pattern. So what does this mean? Means this gene will be carried by those 22 pairs of chromosomes. One. Second thing is this is dominant means that even if one gene is mutated, which is being represented here by this pink color. So this is male chromosome, this is female chromosomes, right? So in male chromosome, main autosomal chromosome, one gene is affected out of 2 chromosomes. Means one chromosome has that mutated gene, other chromosome is normal. Female has both the chromosomes normal, right? But if this, even if this one gene gets transmitted to the child, it will express as a mutation that is known as autosomal dominant, because it is a dominant gene. It does not require a partner gene to express. Okay, so you can see here, this is male, this is female. So the gene, the mutated gene which has gone to the children, boy and girl, they both are being affected by this gene, right? And the gene is not carried to other children, are not affected. Means 50% chances that the next generation will have that affected gene and its expression, right? So that is autosomal dominant. One gene is enough to express. Second is autosomal recessive. Recessive means it needs an affected gene. Like this light blue color is the mutated gene. It needs an affected gene from other parent also to express, right? So it means 25% chances are there that the next generation child will be affected. So one chromosome will come from the father, other will come from the mother, and that is how only 25%. And the other 50% children will be carriers of it. Means one affected gene from father and normal gene from mother, or affected gene from mother and normal from father. So 50% chances are of carrier, 25% chances are of being affected by getting both the affected genes from both the parents together, and 25% chances of child being normal by getting both the normal genes from mother and father. That is autosomal recessive. Means we need both the genes affected to express in autosomal recessive. I think these two should be clear. They were very easy, autosomal dominant and autosomal recessive. Next is X-linked dominant and next is X-linked recessive. Same terminology. Now it is X-linked, means the X chromosome out of X and Y is affected, is carrying that mutated gene. Okay, so this is X chromosome and carrying that mutated gene. Y is normal, and mother has both the normal X chromosomes. Now how many chances that the child will be affected? It is 50%, and that two daughters, because X chromosome will go to the daughter of father have X and Y, and X chromosome will go to the daughter and Y chromosome will go to the son. That is obvious, right? So both the daughters will have this affected gene. Means in X-linked dominant pattern, both the daughters will be affected, right? And the sons will not be affected because they'll get Y from the father, which has normal genes, and will have a chromosome from mother which also has a normal gene. So that is if father has this mutated gene. Let's say in case mother has this mutated gene, things will be different, right? Now one son and one daughter will be affected because this X chromosome will go to son and one X chromosome will go to a daughter. So one son and one daughter will be affected, and one son and one daughter will be normal. This is that son which has got Y chromosome from father and normal X chromosome from mother, and daughter has normal X chromosome from father and normal X chromosome from mother. So 50% children will be normal and 50% children will be affected. And X-linked, this is X-linked dominant, and next is X-linked recessive. X-linked recessive. Recessive means now it has to be from both the parents. Okay, so daughter is, you can see in the image, father X will go to the daughter, of course, and Y will go to the son. Now if daughter has this X chromosome which is affected and mother has normal chromosome, then daughter will be a carrier. So you can see X-linked recessive parents have normal daughters and means carrier daughters and unaffected sons. For example, the biggest example is hemophilia, which is X-linked recessive. There females are carriers and males are affected, right? Now in other case, if this was the case when father had this mutated gene, now if mother has this mutated gene, then that son will be affected, which will have the Y chromosome from father. One son will be affected, which will have Y chromosome from father, and this affected X chromosome from mother. So 25% chances that son will be affected. Daughter will be a carrier because X from mother and X from father. So affected chromosome, if goes to the daughter, then it will be carrier, and other son and daughter will be not affected. So this is what I'm trying to tell you, is just to create an image in your mind. I'm sure when you sit and think over it, you will be able to answer such questions, but still you need to go through these images to create that impression of inheritance. How does it go? How does it work, right? So you'll find such question in AIMS, and this is important. I expect this to be asked again in next 1 year. Right, so with this, we'll start with the disturbances, and first topic out of it is developmental disturbances of jaws. We'll do it one by one. Today we'll be covering all the disturbances except teeth. Teeth will be covering tomorrow. Okay, so rest all will be covering today. So developmental disturbances of jaws. What are we going to cover under it is agnathia, micrognathia, macrognathia, facial hemi hypertrophy, facial hemi atrophy or peri-Robin syndrome, and dental arch relationships. Okay, so these things we'll be going through. First is agnathia. Now we need to learn few things, right? So now actual learning has started. Agnathia is, you need to remember this syndrome first. This is the most common syndrome presenting with agnathia. Okay, this is very important. Agnathia microstomia synotia syndrome. This is also known as autocephaly. Auto, I'm sure you know what do you mean by auto. Auto means it is a autocephaly means relationship of ears with the head. Auto means ears, cephaly is with the head. So it is basically relationship of ears with the head, that is known as autocephaly. It is sometimes used for agnathia, this term autocephaly. Otherwise, the autocephaly represents this whole syndrome, that is agnathia, microstomia, synotia. Now I'll just show the image, then you'll understand. This is, this image is very sad to see though, I would say, but yes, for your understanding, this was important to put here. Agnathia means it does not have any jaw here. There is no mandible, is absent here, completely absent. Ears have reached to this region, you can see. So this is abnormal relationship of ears with the skull, right? So it is an abnormal relationship. That is why autocephaly. Eyes are present, are more widely present, and very small mouth. It is microstomia. So agnathia, microstomia, synotia means abnormal. It is fusion of bones, not proper fusion of bones. That is synotia, and then autocephaly. So this is the only syndrome, the most common syndrome with agnathia. This you need to remember, right? So next is, I have put here this autosomal recessive. These I would recommend you that you write these things: autosomal recessive, autosomal dominant, on one page in your notes of oral pathology. I'm sure you all are making notes on oral pathology in your notebook. I'm sure if you are working hard, right, so definitely you will make notes. In those notes, keep one page separate in which you'll write about all the pathologies which you go through in oral pathology, whether they are autosomal recessive or dominant or X-linked recessive or dominant. That page has to be kept separate, right? So it should not be like you write autosomal recessive on one page, dominant on another page, and then it will be all mismatch. Keep one page separate and write this thing, because this will be one question which will be asked either in AIMS, PGI or NEET in next 1 year. It is asked every year. Out of 240 questions or 200 questions, one question is, they have given the name of the pathology in the question and they have asked whether it is autosomal dominant or recessive. So please keep this on one page in your notes. This is important. Okay. Next is complete jaw is missing. Otherwise, it is very rare that complete jaw is missing, except it is missing in autocephaly, right? So most common is mandible. Anyways, maximum pathologies in oral pathology are common in mandible, then maxilla in general. There are exceptions, but in general it is mandible. In general it is lower lip. Maximum pathologies are in lower lip or in mandible. So I'm sure this is just a general rule. If you do not get any answer and you have to attempt a question, then go by this rule. So agnathia, microstomia, there is autocephaly. Next is micrognathia, that is small jaw. This can be congenital or it can be acquired. If it is congenital, it is of two reasons: peri-Robin syndrome and congenital heart disease. This you need to remember, right? So this congenital heart disease, they have asked a question before, Micrognathia is associated with which of the following pathologies? And they have given 4 pathological terms, general pathological terms. And one of those was congenital heart disease. And this you need to remember, right? So micrognathia is associated with congenital heart disease. Or you can say, if heart is not well, mouth will be smaller, whatever it is. But you need to remember, you need to correlate things. Next is Perry-Robin syndrome. What does this include? This is congenital Perry-Robin syndrome. Is very easy to learn. Cleft palate, micrognathia, and glossitis. How are they interlinked? If you remember cleft palate, rest will be understood, already understood. If you remember micrognathia, these will be understood. How? If I go back to that image, the small jaw, mandible is small. Obviously, if mandible is small, tongue will be falling back. You know what is glossitosis? Tosis means dropping off or falling, right? That is tosis. Glossitosis means falling of tongue. Okay, so tongue will obviously fall when jaw will be smaller. When mandible is small, when it is micrognathic, and we know tongue rests in the floor of the mouth. But when this mandible is smaller, tongue has to fall back. It has to go back. So these both terms are interlinked. Micrognathia and glossitosis both are interlinked. Plus cleft palate, that you need to remember. So this is Perry-Robin syndrome. So this is congenital type. Acquired type means which developed later on after birth, and that is usually because of TMJ disturbances, either TMJ ankylosis or some trauma. But it is acquired, and that is mostly because of TMJ disturbances, the micrognathic. Right. So this is micrognathia. Next is macrognathia. Macrognathia means large jaw, and it is mostly because of endocrinal disturbances. It is pituitary gigantism or acromegaly or Leontius osseous, that is line-like faces in Paget's disease. That is also macrognathia. Right. So these 3 are the reasons for large jaw. These 3 you need to remember, because these 3 have come in a question in the form of 3 options. And fourth was, which of the following is not a reason for macrognathia? And fourth was that option. So these 3 you need to remember, right? So pituitary gigantism, acromegaly, and Leontius osseous, that is Paget's disease or line-like faces. Okay. So if mandible is large in size, what things it can change, what angles it will change, that is important to know, because again this has been asked before in AIMS. Okay. So mandible is, if is enlarged, it will be prognathic. Okay, if it is prognathic, what changes it will bring? One is there is increase in height of ramus. This height of ramus will be increased. There is increased in mandibular body length. Of course, if mandible is larger, everything will get increase in size. So ramus height increases, body length increases. There is increase in gonial angle. This is the gonial angle, the angle between ramus and body. This angle will increase. There is, of course, anterior position of glenoid fossa. When mandible is larger, glenoid fossa will be, I'm sure you know what is glenoid fossa. It is a concavity in the temporal bone where condyle articulates with the temporal bone. This also becomes anteriorly positioned because condyle moves anteriorly because of increase in size. Then is decreased maxillary length is more a relative kind of thing. It is not the actual thing, but yes, because mandible is larger, the maxilla appears smaller in size. Posterior positioning of maxilla in relation to the cranium, it appears so because mandible is anterior now, and maxilla appears as a posteriorly positioned in relation to the cranium. Then prominent chin button because of this enlarged size, and of course varying soft tissue contours according to the length and breadth of this mandible. Right. So all these are very important. What comes with mandible prognathism, you need to know. Okay, what comes with this enlarged mandible, you need to know. So these are important points, and these can come in the form of options. All these points have been given in Schaeffer's as such, so I have put those points here so that you understand what will happen if the jaw size is enlarged, and these are very easy to understand, I'm sure. Next is facial hemi hypertrophy. As name indicates, it is facial. Hemi means half, hypertrophy means increase in size. But actually it is not hypertrophy. We call it hypertrophy, but it is basically hyperplasia that you need to remember. It is increase in number of cells in those tissues of that side of the face. It is not hypertrophy. Hypertrophy is increase in size. I'm sure you know this thing, right? So that one is important. Plus, then large size grows at a rate proportional to the uninvolved side, so that disproportion is maintained throughout life. If let's say both the sides are growing, if I say that right side is hypertrophic side and left side is growing with age, right side will grow the ratio. Let's say if it was 1:2 ratio, it was going to 1 millimeter, it was going to 2 millimeter. That ratio will be maintained. If left side is growing more, right side will grow 2 times more out of it. Right, that ratio is maintained. That is with facial hemi hypertrophy. And on among dental manifestations or the oral manifestations of the hemi hypertrophic side, crown size will increase, everything will increase or will be fastened. Okay, so crown size increased, more in permanent teeth, root size and shape is also increased, rate of development is more. Rate of development is more means primary early exfoliation, permanent early eruption, right? Then as compared to the counterparts on the contralateral side, and of course the jaw size also increases on the hypertrophic side. So this is all hypertrophic. What you need to remember is proportion is maintained and it is not hypertrophy, it is hyperplasia, right? But the most important point of this topic is muscles are not affected. There is no muscular hypertrophy which is being noted on that side. It is the soft tissues, it is the bones which grows, it is not the muscle, right? So muscles are spared in facial hemi hypertrophy. That is the most important point on of this topic, right? So that is hemi hypertrophy. Next is hemi atrophy, which is much more important, also known as Perry-Romberg syndrome. It was given in 1846 by Romberg. What can happen with this is all the manifestations are on the contralateral side because of the stretch, right? So I'll just show you an image. This is the basic manifestation of facial hemi atrophy. What this is also known as Cobb-de-Sabre. Cobb-de-Sabre means the I'm sure you know, it is the hit by a sword, a cut by a sword, healed cut by a sword. That is known as Cobb-de-Sabre. Sabre means sword, right? So it appears like a healed cut by a sword. This term you'll listen, you'll read when you'll move forward to oral pathology in scleroderma also, right? So this term is used in scleroderma also. That is why they say this is basically an early manifestation of localized scleroderma, right? So that you need to remember. If you're talking about scleroderma or if you're talking about facial hemi atrophy, means in options if they've given that this disease is related to which are the following skin lesions, then scleroderma should strike immediately, right? So Cobb-de-Sabre word is used in both the terms, in facial hemiatrophy also and in scleroderma also, okay? And what will happen with this on the contralateral side in the patient will be Jacksonian epilepsy. Jacksonian epilepsy is basically partial or localized seizure in localized area of the brain which is affected. That is Jacksonian epilepsy. Next is trigeminal neuralgia, and there will be changes in eyes, mostly in the eyes and can be in the hair of that side, of the contralateral side. Okay, so three things. These three are important. Again, as I always say, whenever you find three things to learn or four things to learn, expect that as a MCQ in exam, because it is very easy for examiner to frame a question out of it. It will not take much effort, and examiners, of course, they are paid for making questions. So it will be easier for them to frame such questions because it is ready-made kind of question. Fourth option they just have to put, right? So please, do learn these three options: Jacksonian epilepsy, and it is with facial hemiatrophy on the contralateral side, trigeminal neuralgia, and changes in the eyes and hair. Okay, plus the very important point is scleroderma, more common on the left side. With this, I would tell you two other things. Facial hemiatrophy is on the left side. Cleft lip and palate is more common on the left side, but trigeminal neuralgia is more common on the right side. So you can make a box in your notebook and write these three. And this has been asked many times before in various exams, government exams and PGI also. PGI, cleft lip and palate has been asked many times. Cleft lip and palate, as we say cleft, it appears like left, right? So cleft is left, right? So cleft lip and palate will be on the left side. Facial hemiatrophy is on the left side, right? But right side is trigeminal neuralgia. So please keep this in your notes. So that is about facial hemiatrophy. Next is developmental disturbances of lips and palate. So first and foremost is lip pits and fistulas. You can see lip pits Two lipids, they're closer to the midline. They can be present individually also, and if they are present with a cleft, then it is known as Vanderwood syndrome. Vanderwood syndrome. This wood can be, if you, I'll try to write here, this wood can be pronounced as wood, right? You are wandering in woods, for example. Let's say if this question comes in the exam and they ask Vanderwood syndrome, you are wandering in, imagine you are wandering in woods, and what does this wood have? What do you see in tree trunks? In fact, you'll see in tree trunks the cuts, right? So those cuts and grooves and pits is Vanderwood syndrome. Cleft lip, right? So cleft lip and pits, it should immediately strike you. Vanderwood syndrome, right? So don't try to cram it. It is very easy. This wood should strike you. This wood, right? So Vanderwood syndrome. You're wandering in woods and you see cracks and pits on the trees, and that is how you remember. It is lip pits and cleft lip, and these pits are mostly in the towards the midline. They are present medially on the lip, and it is more common on the lower lip. As I told you before, these are most of the pathologies are common in lower lip or in the mandible. So the exceptions you can note down. Otherwise, it is everything lower lip and mandible. You can note down the exceptions which are present in maxilla or the upper lip. Okay, so that this is about lipids. Next topic is double lip. Double lip is, you can see this is one lip, and when the patient stretches or smiles, a soft tissue appears underneath in a bow shape. This gives double lip appearance, double upper lip. And it is mostly common on the upper lip. It is one of the exceptions you can note down, right? So when upper lip is tensed, the double lip resembles Cupid's bow. You can see this is Cupid's bow. But of course, it is not seen when lips are at rest, when they are enclosed. They are approximated, lips are approximated, it is not seen. But yes, when it is stretched, then you can see the double lip. The syndrome which is associated is Ascher syndrome. Now, Ascher syndrome is something like, if you have to remember, Ascher syndrome is like an individual is coming towards you, and when he is about to shake hand with you and he gives a smile, and what you see the double lip. Okay, just a hypothetical situation for you. You see a double lip, and what comes out of your mind? Acha, right? I'm just trying to tell you that this gives you surprise, and acha is kind of Ascher syndrome, right? So you can do it anyway. See, motive is to learn, and I used to learn like this only. You make mnemonics, you correlate things differently so that you remember things differently, right? So acha is for Ascher syndrome. So what this will have is double lip, important. This you should not forget. Next is non-toxic thyroid enlargement. You can see lip here. You can imagine thyroid enlargement. And next is blepharochalasis. What is blepharochalasis? That is, I'll just show you an image. This is blepharochalasis. Okay, this is basically folding of the upper eyelid. That is known as blepharochalasis. In all these terms, three things: double lip also is an extra tissue. Thyroid enlargement is also an extra tissue. Blepharochalasis has also an extra tissue. So that is how you can remember these three things. Even if you don't remember the names and these three are given in options and fourth is something else, at least you will remember that with Ascher syndrome there was something extra in the tissue. So double lip is an extra tissue. Thyroid enlargement is also an extra tissue. Blepharochalasis is also an extra tissue on the upper eyelid. And that is how you will be able to rule out all three options and fourth will be the answer. Right? So that is how you'll remember things. Right, so see, remembering syndromes and cramming syndromes is very difficult. You will not be able to cram every syndrome with every feature of it. Only thing you can do is you can keep these things in your subconscious mind. You can keep this concept in your subconscious mind that in Ascher syndrome you'll find something extra tissue in it. And Asha will be double lip. If someone has come to you for shaking hand and suddenly he smiles and you see a double lip on his face, and then it is Ascher syndrome. So that is all you remember. Okay, next is the very important topic, cleft lip and palate. Most of the theories, most important point you need to understand here is most of the theories, most of the books with earlier editions or even in your pulse, the questions of previous years, you'll find answer is this. What is the etiology of cleft lip or palate? The answer is no. It is due to, it is, forget not here. It is due to failure of fusion of processes. This is the most important, most common answer everybody will give when I or anybody will ask what is the reason behind cleft lip or palate. The answer will be, immediate answer will be due to failure of fusion of processes. But it is not so. It is not so. It is different here. Now this is not recommended, not accepted anymore. Yes, if you do not have this in options, then this can be the answer. Means examiner is someone who is elder, who is old to know this thing. But yes, this is not the reason anymore. The failure of fusion of processes. It is basically failure of mesodermal penetration and the obliteration of ectodermal grooves separating these mesodermal masses that actually constitute the facial process. Means it is not the fusion of ectodermal processes. I'm sure if I try to draw here, this is one process, this is another process. Usually what they say, it is failure of fusion of processes, but actually it is failure of, this is mesoderm of this process and this is mesoderm of this process. This is lined by ectoderm. It is actually failure of merging of mesoderms. Failure of penetrating these grooves. This is a groove, this is a groove. Failure of penetration of these grooves by mesoderm of that process from one side to the other side. So that is the actual reason. It is not the failure of fusion of processes, right? It is the failure of penetration of these grooves by the mesodermal masses that you need to understand. I hope this is clear, right? This is very important to understand. And if this is not given, the option will be failure of mesodermal penetration. One option will be this. Other option, if that is the option and other three are something else, then it is a clear-cut answer. If other option is this, due to failure of fusion of processes is one, and second option is it is failure of penetration. So answer will be failure of penetration. If failure of penetration is not given and this is given, that is due to failure of fusion of processes, then this becomes the answer obviously, because the actual answer is not in the options. So that these all you need to understand what to answer according to the type of question. Okay, so we'll moving on to the next thing now. Cleft lip, also known as hair lip, if it is in the midline. If it is in the midline, it is also known as hair lip because of this hair lip. Right? From here, they give the term hair lip. So more common in males, it is more common on left side, cleft left, very easy to remember. Right? It is highest among Asians. Hereditary is the most common etiology. This has been asked before. Hereditary has been asked, most common etiology for cleft lip and palate is hereditary, has been asked before. Left side has been asked before. Hair lip has been asked before. Right? So these are important questions you need to remember. Next is cleft palate. It is disturbance in the normal fusion of palatal shelves, horizontal palatal shelves. Why do they fail to fuse is these three regions. These are the reasons. In fact, they are not the point. There are three reasons. One is failure to unite due to lack of force. One is lack of force. Second is interference by tongue. I'm sure you know the development of palate, right? When palate is developing, I'll just try to draw here. This is one palatal shelf, okay? And this is another palatal shelf, right? And tongue is in between. What happens, and this is mandible, let's say this is mandible. Initially what happens is the palatal shelves are perpendicular or parallel to each other, both the shelves are vertically placed and tongue is in between these shelves because mandible is smaller that time. Initially mandible is small. As mandible grows and moves forward, this tongue comes down and rests in the floor of the mouth. As it comes down, these shelves, they straighten up, right? They straighten, they become horizontal and they straighten up and ultimately they fuse here. Now, if this tongue is not depressed or does not reach to the floor of the mouth, then of course it will interfere with these shelves and hence they will not fuse and ultimately it will be cleft palate. Now you'll correlate this thing with Perry-Robin syndrome. When mandible is small, tongue will not fall, or if initially it is small, tongue will not fall, and if tongue will not fall, there will be cleft palate. Because it is small, so if tongue is depressed, it will fall down. It will not rest in the floor of the mouth. So all these things are interlinked. It is related to the development of palate basically. And the third is disparity in size, means this shelf is longer or larger in size, this is smaller in size. Because of disparity in size of these two shelves, there is lack of fusion, right? So three factors, again, three reasons, right? So these three reasons are important, can come as three options in the question. So either one is lack of force, second is tongue is interfering between these two shelves, third is disparity in size of the two shelves. So that is important. Again, hereditary is more common than syndromic. And we know cleft lip and palates are more common with syndrome, very common with syndromes in fact, but still hereditary plays a major role, plays the main role, okay? Next is important is the soft palate and the uvula. Bifid uvula is the most mildest form of cleft palate. Mildest form. So this has also been asked before in exam. The mildest form of cleft palate is bifid uvula. Right. So keep this in notes. This is important. This has been asked in fact PGI, not very far. So this was important PGI question. The mildest form of cleft palate is bifid uvula. Okay. So keep these in your notes. Very, very, very important. Again, anything which I have mentioned here in the PPT regarding cleft lip and palate are very important. They are basically the questions which has been asked before, right? So keep all those in your notes. Individually, if cleft lip is present, it is 25% chances that individual cleft lip will present. 25% chances that cleft palate individually will present, but very common is cleft lip plus cleft palate together. So 50% cases have cleft lip and palate together. Cleft palate is more common with blood group O. So how will you remember this thing, right? If this is the palate, if I draw a palate here, and if there is cleft will look like an O. I'm just trying to make you learn thing, right? This is not the exact thing. Of course, this it will not happen like this. But if you have a palate here, this is how you learn, right? If you have a palate here, this palate will have a cleft, and that cleft will be in the shape of O. So it will be more common in blood group O patients. The patients of blood group O, it will be more common on those. Cleft palate has less frequency with A because this shape does not match with A. B also has two round things. This is B, but A is all straight. So this shape is not matching with A, right? So easy to remember. Cleft palate has least frequency to occur in patients with blood group A, right? Most common with O. Cleft lip is both A plus AB, any of. And syndrome association is more with cleft palate and less with cleft lip. Right, so syndromes are more associated with cleft palate. Syndrome sounds larger, palate is also sounds larger than lip. Just to make you learn, okay? So syndrome sounds larger, a bigger thing. Palate is also sounds bigger thing than the lip. So syndromes with cleft palate with O blood group, cleft palate least with A blood group, cleft lip with the both. Two lips, upper and lower lip, so A and AB. Anyway, you can remember. Right, so this is all about cleft lip and palate. Next topic, guys, please respond in the group. Are you getting what I'm telling you? Is it helping you? Please post a message in the group. Are we awake? Are we awake, guys? Important. You're getting what I'm trying to say? Is it helping? I just want yes, nothing else. It can be forceful, whatever. Yes will look good. Okay, thank you. Right, so we'll continue. Next topic is Litus glandularis, right? As name indicates, litus means inflammation of lips. Glandularis means of glands, right? So basically it is inflammatory disease of glands on the lips, right? And glands are more common on the lower lip, right? So it is easy. Litus glandularis, it is an inflammatory disorder. And what happens in this with inflammation of glands is there is progressive enlargement. Lower lip is getting enlarged, and it gets so enlarged that it everts. lower lip evert, and when it everts, the mucosal vermilar interface, it gets obliterated. I'll just show you an image like this. This lip gets everted. Okay, so the most important point to remember with this, this is a kind of lesion which we usually ignore to study, right? But I expect this in exam. I don't know when, but it will definitely come. And why it will come? Because of this reason, because it is a predisposing factor for squamous cell carcinoma. Because when this lip is everted, it will be more exposed to actinic factors. Actinic means sunlight, light factors. That by that we mean actinic means light, right? So it will be more exposed to sun rays, and once the labial mucosa is also exposed. This was the lip mucosa skin. This was the labial mucosa, and this is the vermilion border. Now this area is also exposed. It is more sensitive because this is exposed. It higher chances that it will convert into a malignancy. So squamous cell carcinoma has a very high chance to occur in patients with lateral glandularis. We need to take strict observation and proper treatment of it, like this. Ultimately, this can reach up to this stage. This has to be observed very carefully. This is latus glandularis. So one point you need to remember is squamous cell carcinoma. Plus it has three types: simple, suppurative, and deep suppurative. I'll just write here. You just know the names, nothing else. One is simple. Please understand my writing. Simple. Second is suppurative. Right, suppurative, and third is deep suppurative. Right, so deep suppurative. Simple, of course, is the most simplest form, which we saw in the first image. Suppurative, what we saw in the second image, and third is deep suppurative, which will have huge abscess draining sinuses from the lower lip. That will be deep suppurative. This is the most severe form. This is the most simplest form. So this is also the most easy to cure. Right, so these three names you need to remember: simple, suppurative, and deep. This is non-suppurative. It will not have any abscess. These both are suppurative. So that is all you need to know about this topic. We'll move on to the next thing. Next is Platus granulomatosa, motasa, right? Matosa sounds like motasa, you know? So matosa means motasa, means lips will be nodular, means lips will be motasa. So M for motasa, M for Meschers syndrome, M for Melkerson-Rosenthal syndrome, all are in this lesion. M, you need to remember M, and all will be covered. So Platus, again inflammation of lips. Granulomatosa, lip will be motasa, enlarged lip, right? And it is seen in Meschers syndrome, or it is also known as Meschers syndrome, again with M. So it has nodular swelling of lips, plus this is one of the features of Melkerson-Rosenthal syndrome, which has three things: facial paralysis, scrotal or fissure tongue, and Platus granulomatosa. Right, so these three things are seen in Melkerson-Rosenthal syndrome, and this is again very important. 3 is an important question: facial paralysis, fissure tongue, and Platus granulomatosa. It is seen with Melkerson-Rosenthal syndrome. You need to remember it. Very, very important question. Melkerson-Rosenthal. If I write here fissure tongue instead of scrotal tongue, then facial and fissure sounds almost similar, right? So F here, Melkerson. Facial paralysis, I'm sure you will correlate immediately with Melkerson-Rosenthal syndrome. This is very common with facial paralysis. Right, Latus granulomatosa, M matosa, M Melkerson should not be a problem. If you remember this thing, if you remember this image of this PPT, and you correlate this chapter, when you see this question in your exam, see sometimes what we do when we see a question in exam, we don't know the answer, but we know the topic. What we do is we tend to think of the book or that presentation or those notes where we think we have read that topic, and somewhere in our subconscious mind memory we go back, we close our eyes, and we try to reach to that page, and that is only possible with revisions. right? It will not happen if you read it once or twice. It will need revisions definitely, but if you do good number of revisions, you will definitely reach that page where you have written, or at least you will remember the right page or the left page or the top corner of the page or the left corner of the page. Definitely you'll reach to that point. If you reach to that point, then these images which I have done here is these images, this metosa, this M capital of Melkerson, then these images will strike you. These all will happen only if you revise, if you understand properly, if you make effort to learn. If you just make effort to cram these things, then it will not happen. But if you make an effort to learn these things with mnemonics and correlations, only then it is possible. And sometimes you solve questions this way only, through your subconscious mind, right? So Melkerson, M for Melkerson, M for metosa, M for mesher. Easy, I think. Then is facial, F for facial, and F for fisher tongue or scrotal tongue. So should not be easy, should not be difficult. No, sorry, should not be difficult, of course, right? So this is how you remember this, and this syndrome has lattice granulomatosa. Done. Next, very important, which again I think if examiner have to put a question, difficult question, then this is the one out of this topic. Melkerson-Rosenthal syndrome sometimes is a manifestations of Crohn's disease. Or Crohn's disease, you can see, of course, if syndrome is a manifestation of Crohn's disease, means Crohn's disease can show all these three things which are given here: facial paralysis, scrotal tongue, and lattice granulomatosa. So basically this question can come indirectly in your exam. Which of the following is not seen in Crohn's disease? They'll give all these three options, okay, or they'll give name of the syndromes, out of which one syndrome will be Melkerson-Rosenthal and three other, and you have to identify, you have to name, mark the right answer. So answer will be Melkerson-Rosenthal. So Crohn's disease you need to remember. Crohn's is with lattice granulomatosa. Squamous cell carcinoma is with glandularis. So this you should remember. Okay, next is Peutz-Jeghers syndrome. Very easy. Everything is P here. Like in Melkerson-Rosenthal, everything was M. It is everything P here. P is for Peutz-Jeghers syndrome. It has hereditary intestinal polyposis, again with P. It has melanin pigmentation, again with P. And it is autosomal dominant. Where you have to write down, I'm sure you know now, in that page, in that separate page in neuropathology, right? So hereditary, it has intestinal polyposis like this, right? It has polyps, the growths in the intestine. So this is intestinal polyposis. Plus it has pigmentation. This pigmentation may fade after puberty, again P, right? And this pigmentation is basically, where we see this pigmentation, it is perioral, P, perinasal, perianal, right? Basically around the openings in the body, right? And it crosses the vermilion border. It can go to the labial mucosa also. But very important is this: polyposis of colon is also seen in Gardner syndrome, but they are malignant. They have malignant potential. Gardner, as name indicates, it is a garden. So Gardner means garden. Garden means it will have many polyposis. Many polyposis means higher potential to get converted into malignancy, right? So that is all you'll remember. Gardner syndrome polyposis have potential to get have malignant potential, and polyposis of Peutz-Jeghers syndrome do not have potential to transform into, they are benign. These polyposis are benign growths, right? So I hope this will help you in remembering. Next is, this already told you, size is 1:5 millimeter. Again important. The size never grows more than 1 centimeter. It is 1 to 5 small pigmented areas. This is all extraoral. Intraorally, most common site is buccal mucosa, right? Next is, the polyps are more common in small intestine in Peutz-Jeghers syndrome. And Gardner syndrome, it is large intestine. Again, Garden, large intestine. Garden, more, higher potential, malignant potential. So polyposis of Gardner syndrome have higher potential and they are in large intestine. Polyposis of Peutz-Jeghers syndrome are small, they are small intestine and they do not have high malignant potential, right? So I hope all the points of Peutz-Jeghers syndrome you will remember now, right? So I'll just move back the slide and just review it. Polyposis, pigmentation, puberty, perioral, perinasal, perianal. It can affect other parts of the body also, though it can affect fingers, it can affect toes, but these are the most common sites. Okay, next is I'll just show you the images where see in perioral it has crossed the mammalian border. You can see here pigmentation. It is also seen on buccal mucosa, and these are the sites, lips. This is on hands. You can see fingers. It is buccal mucosa. There also you can see. This is Peutz-Jeghers syndrome. Next is developmental disturbances of oral mucosa, and the most important question out of it is Fordyce granules, and I'm sure you know this thing. These are heterotropic collections of sebaceous glands, right? These are ectopic sebaceous glands, and like this, you can see these small yellow dots on the lips. Lips and buccal mucosa are the most common site. Out of these two, buccal mucosa is the most common site. It is basically an entrapped sebaceous gland during embryogenesis, more common in adults. And this is also when they describe question, sometimes it mention it like this: rice-like granules on lips. And you have to see options. One of the options will be Fordyce spots. So rice-like granules, rice. I hope you all are not hungry. See, rice-like granules on lips. So this term is used for Fordyce granules. Okay. So easy, I think very easy. This is buccal mucosa. You can see yellow dots on the buccal mucosa, Fordyce granules. What is the treatment? We don't do anything. They are harmless. They are innocent. We don't do anything with these. We let it like this only. Okay, so that is next is Heck's disease. Heck, as name indicates, heck of a disease. When we use this word heck of a disease, right? So heck means it is not good. Heck of a disease, right? So it is not a good disease. So that is why HPV, which affects is 13, because we say 13 is an unlucky number. So heck of a disease is caused by HPV 13. That is how you'll remember, right? So should be easy now, because again you can keep this in your notes. HPV, which type of HPV causes what? Again, make a box in somewhere in your notebook and write. You'll find around 5-6 examples of HPV infections. One is Heck's disease, squamous cell carcinomas, dysplasias, papillomas. They're all caused by HPV. Different number of viruses. This is the number given to the species of these viruses. So HPV 13 causes heck of a disease. Heck of a disease, 13 is unlucky, so correlated. Next is it is focal epithelial hyperplasia. Heck of a disease is epithelial hyperplasia. So this is also important to remember. Lower lip is, as I told you, but in appearance is this cobblestone appearance. You can see white dots here. This is heck of a disease, Heck's disease. This is hyperplasia. Focal, it is just focal epithelial on the epithelial hyperplasia, that is why white. Focal epithelial hyperplasia is heck of a disease and is caused by HPV 13. This is important out of all this. You need to remember. Next is developmental disturbances of tongue. Very, very important. Very important. Okay, so first is aglossia, microglossia, and macroglossia. Out of this, macroglossia is something which has been asked before many times. And what syndromes are associated? Basically, Down syndrome is associated with macroglossia also, and it is also associated with scrotal tongue, Fisher tongue. We'll see it when we read Fisher tongue. We'll see Down syndrome again, right? So next is, this is the most commonly asked syndrome with macroglossia, Beckwith-Wiedemann syndrome. When I say Beckwith, do you hear Bakwas? Right? When I say Beckwith, it sounds like Bakwas, right? Beckwith, Bakwas, right? Kind of that thing. So, and Wiedemann. Bakwas we do with tongue. When we'll have large tongue, we'll do more Bakwas kind of thing. So Beckwith-Wiedemann syndrome is with macroglossia, with larger tongue. So this syndrome you need to remember. Beckwith-Wiedemann syndrome is macroglossia. Down syndrome, macroglossia, and Fisher tongue both. Okay. If tongue is enlarged in a normal jaw, okay. If tongue is enlarged and jaw is also enlarged, that is basically, I would say, is an endocrimal disturbance. For example, in acromegaly patients, there you will find enlarged tongue also. You will find enlarged jaw also. There you will not find crenation or scalloping on lateral borders of tongue. But if tongue is enlarged and jaw size is normal, there you will find crenation. What do you mean by crenation? I'll just try to show you that image. You can see crenations. These are depressions on the lateral border of the tongue. How do they happen? Basically, this higher point of crenation goes into the interdental spaces, and this is behind the lingual surface of those teeth. So basically the teeth, because tongue is growing and teeth are stable, these crenations are because of the teeth present in the jaw, which leave the indentations on the lateral border of the tongue. So whenever crenation word is used on tongue, assume it is macroglossia. Okay, or you can see, or they give a history like the patient has a large tongue with crenation on the lateral border of the tongue, which of the following syndrome is associated. So Beckwith Wiedemann syndrome is, it must be in the options. Definitely it must be in the options, right? Next, this already told you, acromegaly. Next is ankyloglossia. Ankyloglossia, we know it is a tongue tie, but there is a difference, right? True ankyloglossia and false ankyloglossia. True ankyloglossia was asked in PGI 2-3 years back. What do you mean by true ankyloglossia? True ankyloglossia is basically the actual union or fusion of ventral surface of tongue with the floor of the mouth. That is true ankyloglossia, means it is not tongue tie, it is not short frenum, it is not short lingual frenum. That is not true, that is false ankyloglossia. True ankyloglossia is complete fusion of ventral surface of tongue with the floor of the mouth. There is no frenum, right? So that is true ankyloglossia. False is what we all usually know, tongue tie, small frenum, short frenum, right? So that is false. True is complete fusion. That is all you need to know out of this topic, right? So move on to the next thing, scrotal tongue, like this, or the Fisher tongue. Where do we read Fisher tongue before? Please post a message in the group. I want to know, are we awake? Where we read Fisher tongue before in today's lecture? Let's see how many answer. Guys, are we awake? Yes, somebody's typing. So Fisher tongue was, we read in which pathology? Okay. It is Melkerson-Rosenthal syndrome, yes. It is not cheilitis granulomatosa. Cheilitis granulomatosa is an individual pathology, separate pathology, right? It is not linked with scrotal tongue. But if it is linked, then we are talking about Melkerson-Rosenthal syndrome. I hope this is clear, right? So cheilitis granulomatosa is a separate pathology. These two are not interlinked otherwise, but if they are, then we are talking about Melkerson-Rosenthal syndrome, right? So keep this thing in mind. Now, immediate before this is one thing. Another thing which I just told you in lecture but didn't show you in PPT, scrotal tongue is also seen with other syndrome. I just showed you in 1 or 2 slides before. This is already shown on the slide PPT, right? So Melkerson syndrome plus Down syndrome, right? These two shows scrotal tongue. Down syndrome also shows large tongue, microglossia, right? So this is Fisher tongue. Next is median rhomboid glossitis. Now you need to listen this very carefully because Pulse has different answers and questions. Pulse has around 2-3 such questions based on the etiology of this median rhomboid glossitis. Okay. Earlier theories used to say it is because of lack of tubercular impar. Basically, what I just try to show you here with diagram, then you'll be able to understand. If this is the tongue, if this is a tongue, though it is not looking like a tongue though, but if it is a tongue, and this is the anterior 2/3 of the tongue, this sulcus terminalis, they will find foramen cecum embryologically. Usually there is tuberculum impar if present here and no papillae are present. Earlier they used to believe that this is tuberculum impar, or the persistence of tuberculum impar in this sulcus terminalis lead to median rhomboid glossitis. This was the old concept. New concept is, this is not the theory. New theory is, it is basically an candidal infection, localized candidal infection, because of which papillae, it is depapillated from this area and hence it appears inflamed and erythematous and it is median rhomboid glossitis, right? So my point is, if you get a question, question states the etiology for median rhomboid glossitis, and the options are, option A is persistence of tuberculum impar, option 2 is depapillation of filiform papilla, option 3 is Candida albicans, right? So answer here becomes Candida albicans. If Candida albicans is not given in options, then answer becomes persistence of tuberculum impar. If both these two options are not given, then it is depapillation of filiform papilla. So this is how you will answer this question, sequence priority wise. Right, so you need to see which option suits best to the question. So first best answer is, it is basically candidal infection. Second best answer only because it was believed before, and we just assume that the examiner has put this question from some old book, and that option will be persistence of tuberculum impar. If both these two are not given, then third answer will be depapillation of filiform papilla. So keep this in mind and accordingly answer whatever answer is given in your books in Pearls or AIMS 25 years, but keep these 3 points in your mind and answer accordingly. Okay, please don't change this. This is the basic concept of this topic. Right, so this is also known as central papillary atrophy of tongue because there is depapillation of tongue. Now because it is confirmed that it is Candida albicans infection, it is also known as posterior midline atrophic candidiasis. It is considered as a type of candidiasis on tongue. So posterior midline atrophic candidiasis. If this term is given to you in question, I'm sure you will be able to answer. They are talking about what? Posterior midline atrophic candidiasis term is used for median rhomboid glossitis. I'm sure you will be able to remember. There should not be any confusion, right? So moving on to this topic. Next topic is, see, it is also known as kissing lesion. I'll show you an image. Kissing lesion, because why they confirmed this as a candidal albicans infection, because what they saw was similar edematous patch which was seen on the dorsum of the tongue, was similar patch was seen on the palate, just opposite to it. So then they assumed that it must be some infection which is getting transported or transferred from tongue to the palate. And when they identified, when they found this thing, they found that Candida albicans is the etiological region. So that is why we call it kissing lesion, right? Now, if this is kissing lesion, then what is kissing disease? Again, a question for all of you, just to see how much you remember oral pathology. I need an answer in this group. So if kissing lesion is median rhomboid glossitis, then what is kissing disease? Perfect. Epstein-Barr virus disease, okay, not bad. Infectious mononucleosis caused by Epstein-Barr virus, okay. Right, so kissing disease is basically infectious mononucleosis. So I'll just show you those images. This is kissing lesion, and we are talking about median rhomboid glossitis. Now you can see it is of same patient. So median rhomboid glossitis and similar kind of erythema was seen in the palate, posterior palate, where tongue was touching the palate. So it is kissing lesion. Next is kissing disease is something like this. It is infectious mononucleosis. There we see pseudomembrane formation. So you can see pseudomembrane formation, and this is kissing disease. It is infectious mononucleosis, right? So keep this thing in mind. Next is benign migratory glossitis. As name indicates, benign migratory means it is moving. Glossitis means inflammation. Wandering rash, same thing, it is moving. Geographic tongue, because wherever there is inflammation or depapillation of tongue, it gives an appearance of some map of a country, right? So geographic tongue. So what is important to remember is, see, median rhomboid glossitis, keep this in mind. I am repeating this thing because this has been asked many times before. Median rhomboid glossitis is associated with candidiasis 1. Benign migratory glossitis is associated with psoriasis. These two should not be confused. When I take a lecture, when you will do MCQs here from your books, I'm sure you will remember. But when this question comes in exam, we usually confuse this thing. I have got these silly mistakes from students from last years. When this question comes in exam, they usually get confused that psoriasis was with benign migratory glossitis or it was with median rhomboid glossitis. Please, whenever you think of median rhomboid glossitis, think of kissing lesion, think of the etiology, right? Then you will understand, then it will be sorted. But if you cram it, and if you try to cram these things, relations, then you will confuse, right? So please understand the etiology of median rhomboid glossitis, then this becomes easy, right? So benign migratory glossitis or wandering rash is associated with psoriasis, right? It is psoriasis, and it is confirmed histologically also. Histologically, it has microabscesses and Monroe's abscesses, which are usually seen with psoriasis. Histological appearance is same as that of psoriasis. It also has test tube retipex, which is a feature of psoriasis, plus club retipex. Club retipex means, if this is the epithelium, retipex will be elongated, test tube shape, one, plus they will be clubbed. Clubbed means it will be like this. They will be fused at the bottom. So test tube like and fused, this is known as clubbed retipex. It is a typical feature of psoriasis. Elongated test tube shape and clubbed retipex is a feature of psoriasis, plus Monroe's. Monroe's abscesses are basically small micro abscesses in the epithelium. Usually we do not see any abscess in the epithelium. Usually we do not see any inflammatory cell, collection of inflammatory cells in the epithelium. But if we see a collection of inflammatory cells in the epithelium, then we are talking about micro abscesses or Monroe's abscesses, right? So these all are the features of psoriasis which we see in geographic tongue, right? So please keep this thing in mind. Next is, of course, it is desquamation of filiform papilla. See, whichever lesion pathology we have read till now of tongue, everywhere we have seen desquamation of filiform papillae. Or in other words, if I say in general a rule of regarding tongue pathologies, it is basically filiform papillae which are affected most. Either it is desquamation or depapillation of filiform papilla, or it is elongation of filiform papilla, like in hairy tongue. Okay, so mostly it is filiform papilla which are affected. Why I'm telling this thing? Because if you get confused, remember, if you get a question in exam and they ask the types of papilla, which of the papilla gets depapillated in geographic tongue, and you are not sure, remember this thing that filiform papilla are the most common papilla which are affected with pathologies. Okay, either it will be desquamation or it will be hypertrophy of filiform papilla. That you need to remember, except two lesions. This you can note in your notebook. Two lesions. One is strawberry tongue, that is seen in scarlet fever, and dysautonomia. Functional dysautonomia is another term where taste sensation is lost. Functional dysautonomia. So two lesions where you will find fungiform papilla affected. In scarlet fever and functional dysautonomia, fungiform papilla are affected. Otherwise, in every other pathology of tongue, you'll find filiform papilla to be affected, either desquamation or their elongation, right? So this you need to remember. Plus, if filiform papilla are depapillated, fungiform papilla are persisted, means they are not affected. In short, you can say this thing. If you don't remember this thing like this line like this, and this line obviously means that fungiform papilla were normal, they were present there, and filiform papilla are depapillated, and they appear as red dots. Why red dots? I'll just try to draw the diagram again. Basically, fungiform papilla are like this, right? These fungiform papilla are non-keratinized. One, filiform papilla are like this. They are keratinized, right? Filiform papilla are keratinized. They are white in color. That gives white color to the tongue, or rough surface to the tongue. Filiform papilla. Fungiform papilla are non-keratinized. One. So one reason they appear red, because they are non-keratinized. Second reason, the cores of connective tissue, they go into the depth of the papilla. This core of connective tissue reaches the height of the papilla to support this proliferation, right? Because it is connective tissue, it will have blood vessels. That is also, this papilla is more red than filiform or circumvallate. So red color or pink color of the tongue is because of fungiform papilla. This is a general thing. Red dots is not something which is present only in this lesion. Red dots is a general thing, that red dots on tongue are basically because of fungiform papilla, because they themselves are more red in color because they are not keratinized. Filiform papilla are fully keratinized, filiform fully keratinized, and they are white in color. That combining both these two, it gives a pinkish appearance to the tongue, right? So this you need to remember, and very easy to remember, I believe. Next is very important. As I told you, in psoriasis, retipex are test tube shaped and elongated. But if we see a geographic tongue with non-elongated retipex, they have Monroe's abscess, they will have microabscess, but retipex are not elongated. If that is the case, then do expect this syndrome, Reiter syndrome. This is again very important. This has been asked many a times before. Syndrome associated with geographic tongue. It is Reiter syndrome. Okay, so do remember this. This is very important and has to be in your notes with bold letters, right? So Reiter syndrome, but when we consider this only when retter ridges are not elongated, like usually. Usually giraffe tongue will have elongated test tube shaped retipex, clubbed retipex, but in Reiter syndrome, it will have a geographic tongue, but retipex will not be elongated, right? So that is Reiter syndrome. Keep this in notes, very important, right? So next is we are about to end today's lecture. We're reaching the last topics of the lecture. Next is hairy tongue. As I told you, again hypertrophic filiform papilla. Hairy tongue will appear like this. This is hairy tongue. These are basically filiform papilla of tongue which are elongated and they are discolored because papilla are elongated. It is difficult to clean the tongue, and whatever we eat, tea, coffee, whatever we eat stains these papilla, and hence the color is blackish, brownish black color on the surface of tongue, which gives hair-like appearance, but they are not actual hairs. They are filiform papilla, elongated filiform papilla, okay, which gets colored, or better word will be it gets stained, okay. So it is more common in males, because males are very poor in maintaining hygiene. One. Second is patients with HIV infection, very common. Hairy tongue is very common with HIV infection. Intravenous drug users. This is basically the drug addicts. Okay. People with poor oral hygiene, of course, and people on soft diet, because with hard diet, or you can say the fibrous diet, of course, will clean the tongue and will not let filiform papilla to grow. If we are on soft diet regularly, or if we are in hospitalized and not having food, and we are on some IV treatment, then high chances this papilla will be hypertrophic and will lead to hairy tongue. So this is hairy tongue. Now I'll show you another image, contrasting image, but that is hair on tongue, not hairy tongue. It is hair on tongue. See, this is actual hair. This is not proliferation of filiform papilla. Now, why such kind of appearance on tongue? It is basically during reconstruction when we take a graft from skin and which is ill planned or was in some emergency. We took a graft from skin and we built this tongue because skin has an inherent potential to form hair follicles. It has hair follicles to form hair. So that is how these hair they grow on lateral border of the tongues. This is unavoidable because we have to take a graft, and sometimes it is very irritating to the patient also. So, but we can't help it, right? So that is hair, and this is not hairy tongue. Okay, so hairy tongue is actually this, which is elongation of papilla. Next is developmental disturbances of salivary glands. Easy topic, very important, has been asked many times. Static bone cyst or Stepney cyst. S and S. Static bone cyst or Stepney cyst. What it is basically? It is basically when we see radiograph or OPG of a patient, what we see is radiographically we see a well circumscribed depression on the or radiolucency on the this body of the mandible, right? And what it is actually, it is basically depression on the lingual side of the body of the mandible where submaxillary gland is basically submandibular gland, right? So submandibular gland is present in that depression on the lingual surface of the body of the mandible. It is during the development. During development, this gland is left on the body of the mandible in a depression. And when we see radiographically, we see it like this. It appears like this. It is basically depression, giving a cyst-like appearance. Though it is not a cyst, it gives a cyst-like unilocular cyst-like appearance. It is a gland on the lingual side of the, I'm repeating, it is a submaxillary gland and trapped on the lingual side of the body of the mandible, right? So I hope this is clear, very easy. Plus this is an ovoid radiolucency, and very important point, it is present between the mandibular canal and the lower border of the body of the mandible. It is present between canal and lower border of mandible. This you need to remember, very important, because it is a differentiating feature. This is again the same thing. It is a differentiating feature from this lesion. This is basically traumatic bone cyst. How do you know it is a traumatic bone cyst? We can see this cyst is growing between the teeth. This is known as scalloping. This is known as scalloping border of the cyst. It is going between the teeth, interdental areas and interradicular areas. And this is a characteristic feature of traumatic bone cyst or hemorrhagic bone cyst. And you can see this cyst is superior or above this mandibular canal. Both these cysts are common at the angle of the mandible, but this staphnous cyst is below the mandibular canal and traumatic bone cyst is above the mandibular canal. Yes, it can push the mandibular canal down. That is possible. This can push the mandibular canal to the lower border of the mandible. That is highly possible, but it is mostly present above the mandibular canal. So this is traumatic bone cyst. This you need to remember. This has been asked before, right? So please understand the difference between these two and their location. So that's it. Thank you so much for listening me. I hope it helped you. It helped you remembering things. It helped you learning few concepts, and I'm sure you'll be able to recollect whatever I told you. And tomorrow we'll have a quiz of 5-10 minutes before I start next topic. Next topic is developmental disturbances of teeth. Very interesting again, very important, and I'm sure we'll learn it well next time. Thank you so much for listening and study hard. Good night. Make notes. Good notes. Good night, everybody.